workplace incivility and bullying is any negative behavior that demonstrates a lack of regard for others.
Bullying exists. Call it what it is. It can lead to a loss of valuable human capital and medical errors.
Hi, I'm Dr. Beth Bullock.
And I am Dr. Cole Edmondson. We are Robert Wood Johnson Executive Nurse Fellows and members of the project team which developed the Civility Toolkit, resources to empower healthcare leaders to identify, intervene, and prevent workplace bullying. This video from the Courage bucket of the Civility Toolkit was designed to help those of us who work in healthcare to learn to respectfully manage conversations regarding incivility or bullying in our workplaces. It is the second video in a three-part series.
The objective for this video is to describe the approach to respectful conversations for difficult situations. These conversations are referred to as difficult and crucial conversations because they are emotionally charged, there may be a power differential between those having them, and there's often a fear of retribution for expressing one's feelings and perceptions. Difficult conversations are just that, difficult. Difficult conversations take courage to participate in from both the giver and the receiver's perspective. However, difficult conversations must occur. They are crucial so that true communication and collaboration can be reached. They occur at all levels of an organization and between every profession. Of the many terms that can be used for these conversations, we suggest that we use the term respectful conversations for difficult situations to keep our goal of civility at the forefront. Numerous authors have recommended approaches to these difficult, crucial, and respectful conversations. Each approach manages the conversation through a series of steps. Regardless of the steps and which approach you choose for your purpose, these conversations are a skill to be learned, just as we learn to take a blood pressure, complete a history and physical examination, or write a business plan.
In this approach, we will be using a series of 5 steps for our conversations. To keep these steps handy, please download the pocket card from the Courage bucket of the Civility Toolkit. It can be printed on cardstock and laminated for durability. There are 5 steps for respectful conversations for difficult situations. The first step is to plan for the conversation. Well thought out planning leads to conveying accurate information and creating an environment conducive to communication. First, validate the information to be shared, especially if it came from another party. For example, if you are the department's nursing manager and you will be speaking to the attending physician on call from Friday night, and the conversation is regarding an incident between the attending physician and a nurse, the information needs to be reviewed for accuracy and completeness before the meeting is planned. Determine who were the incident's bystanders and if there were any additional collaborators. Find out if patient outcomes were impaired. Next, determine the focus of the conversation. The conversation will not be valued if it is to cover every episode of incivility from over the past year between the collaborators, or if it is extended to other parties. For example, a focused conversation might be regarding just the incident Friday night at 8 p.m. when Nurse Jones tried to reach attending physician Doe regarding a patient concern and was told to stop calling, everything is fine. The nurse reported feeling bullied to stop reporting her patient concerns and was troubled that should this occur again, that the patient care might be impacted. Part of Step 1's focus is to plan ahead to Step 5. What will be the follow-up for the conversation? Is this an ongoing problem or the first incident? Will there be administrative action? Will there be restorative justice such as occurs with an apology? Or is this conversation the first and one to bring awareness to the individual regarding the impact of his or her actions? What occurs after the conversation depends on the history of incivility and bullying and previous conversations and improvement plans. Next, plan to create an environment conducive to the conversation. Depending on where the offender is in the disciplinary or conversation process, the conversation might be over a cup of coffee, as recommended by the Joint Commission, or in another location. Where is that other place? The middle of a busy unit? Your office? Another office or available space? Are there chairs so that you can sit at the same level? Is there a door so that the conversation can be private? Some conversations will be emotion charged. Will the location support some privacy if a person is emotional or needs a private moment following the conversation? No two conversations are the same, so no two location requirements are the same. Match the location with the intent of the conversation. Plan enough time for the conversation and prevent interruptions. If telephones, smartphones, and pagers are present, be sure to make it clear to the participants, in this example, to the attending physician DOE, that you will give your undivided attention should the telephone ring or pager vibrate. Best practice, though, is to turn these devices off or to silent mode during the conversation, or ask others to answer while you're occupied. Interruptions make difficult conversations all the more difficult and are not respectful when the interruptions are avoidable. Determine who needs to be invited to the conversation. Is it just attending physician DOE? Do multiple conversations need to be planned? One conversation might be with the attending physician, another might be with the nurse, and another might be with the bystanders to the Friday event. Remember that the bystanders can be affected just as strongly as the collaborators. Thus, if the nurses on the unit witness the exchange between their colleague and the attending physician, they might also be disinclined to call that physician when they are concerned regarding a patient's status for fear of being yelled at too. Plan the meeting or meetings accordingly. In this example, the meeting will be with attending physician DOE only.
Step 2 is to check perception. How you are perceived is more important than what you say. Regardless of the focus of the conversation, you want to be perceived as being a good listener, a team player, a person with the best intentions for everyone's safety, security, and well-being. And above all, you want to be perceived as respectful. So use the language of collaboration. You don't want to use words that invoke a negative response or are considered judgmental. You also don't want to use body language that is perceived as rude, inattentive, or closed off. Good listeners lean in slightly to the conversation. In our respectful conversations, we will employ a modified Center for Creative Leadership format: situation, background and behavior, and impact. In step 2, you will structure your comments using the first two elements: situation and background and behavior. For the situation, you will start the conversation with the reason for the meeting. Be brief, then stop. Using our example, you state that you want to discuss the incident from Friday night at 8 p.m. when Nurse Jones called regarding a patient concern. She came to you because she was very unsettled after your conversation. Stop. Think of the conversation as an unfolding story. Do not start with too much information. Do not start with pointed language such as, when you told her to stop calling you. Pointed language becomes personal, contributes to an already emotionally charged conversation, is disrespectful, and will close down communication before it even begins. Ask for the other person's perception of the event. What was the background and behavior to the situation from his or her perspective? Say something like, "Please tell me about that evening and what led to the conversation between Nurse Jones and you." Listen quietly, attentively. Only interrupt to check information or ask the other person to expand on a comment, to please tell you more. Letting the other person go first in the conversation opens communication and demonstrates your respect for the other person's perspective. This step can be very hard to perform and takes much practice to gain skill because most of us find it hard to be a good listener. In our example, attending physician DOE states, that he was on the unit all day on Friday, and that after he left, the nurses called him at home every 5 minutes all night long with what he considered to be non-emergency issues. He said that it was frustrating and then difficult to return the next day rested. He said that this happens every time that he's on call.
Step 3 is to deliver the message. When the other person has completed his or her perspective, you will use the same structure for your comments, situation, and background and behavior. However, this time you will add impact, which is usually something related to building and sustaining human capital or patient outcomes. Repeat the situation and provide more detail from Nurse Jones' perspective. On Friday night, when Nurse Jones called you regarding patient Smith's escalating blood pressure, she reported that you told her not to worry, everything would be fine, and to stop calling you. Provide background and behavior to Nurse Jones' perspective. Nurse Jones was very concerned that patient Smith was at risk for a hypertensive crisis and that his escalating medical needs were not being attended to. She had been at his bedside all afternoon, and the slowly increasing blood pressure was a significant concern for her. The family approached her several times asking what the doctor was going to do about it. Nurse Jones was warned by her colleagues that she shouldn't call you after 7 p.m. unless it was a clear emergency. But she felt that this was important and the blood pressure trend was worrisome. She wanted you to know about the situation, determine if anything needed to be done immediately, and prepare a plan for the next hours. She is an excellent nurse with strong critical thinking skills. Last, you describe the impact of the situation on building and sustaining human capital and/or impairing patient outcomes. The result of the incident on Friday night was that Nurse Jones felt disrespected, devalued, marginalized, and bullied. The bystanders in the incident, the family, and the other staff were concerned. This time, patient Smith did okay. However, Nurse Jones and the other nurses are worried that the next time they need to call you, that they will hesitate and that it might negatively impact the care of their patient. Nurse Jones is considering resigning or moving to another unit. Pause. Let the other person gather his or her thoughts and respond. Listen attentively.
Step 4 is empathy. This step is overarching throughout the conversation. Provide a gracious space and safe setting with good intentions and respect throughout the conversation. Be comfortable with pauses and silence and truly listen. Be sensitive and straightforward. Put yourself in the other person's shoes.
The last step is to summarize and plan for follow-up. Review the highlights of the conversation. For our example, it might be that Friday night communication failed between team members, which could have resulted in a poor patient outcome or the loss of a valuable nurse. However, it sounds like the system of each nurse calling the attending physician on call results in excessive calling and is an ineffective process for everyone. Check for understanding that the summary is correct. Determine what is to follow before the meeting and review the plan. The nurses are at the bedside 24 hours per day and are astute at recognizing patient changes, though they may not always be able to articulate as clearly or in the language that you prefer. They are looking for immediate responses even in non-emergent situations. We all want a high-functioning team, to feel good about our roles in the system, and to help our patients in any way we can. Everyone needs to feel respected and valued. It is clear that we need to change our after-hours process, notifying the attending physicians regarding patient changes. So the plan moving forward will be that questions from the nurses will be filtered through the charge nurse to group calls to the attending physician on call periodically through the evening, unless it's an emergency. I think that an apology from you to Nurse Jones and the other nurses will go a long way to repairing your relationship with them. I hope that Nurse Jones accepts it and changes her mind about leaving the unit. If you agree, let's meet in 2 weeks to determine if the plan for the charge nurse grouping contact with the attending physician on call is effective or needs to be revised.
Emotions and tension often run high with the increasing acuity of many settings and the numerous stressors, especially for productivity, that we all face in healthcare. How we handle these situations defines who we are. We hope that this tool helps you respectfully approach conversations for difficult situations. In this second video, we describe the approach to these conversations. Plan for the conversation, check perception, deliver the message, empathize, and summarize and follow up. In video 3, you will view 3 vignettes of incivility or bullying and modeled responses.
This tool from the Courage bucket of the Civility Toolkit was designed by a Robert Wood Johnson Foundation Executive Nurse Fellows Project team, the PACERS. We chose this acronym because we are passionate about creating an environment of respect and civilities in healthcare. The project team members are listed here for you in alphabetical order. Without the group's wisdom and passion, this tool would not be possible.